So, welcome all. Team Decode MRCOG hereby discussing a very important topic. What we have observed, this is an important topic which will assess your ability to pass the exam. At the same time, it will assess, means it is a domain which will help you to score more also. So, core surgical and labor board, these are the two domains where you will, if you are confident enough, you will excel, you will score, and at the same time, if you have difficulties in other tasks, at least this domain, this task will help you to pass and clear the exams also. The people who attempted and didn't do good in this labor board, many a times we have seen unfavorable results with them. So let's go. What we are going is the division of today's topics, how we are going to go today. The firstly, we will be going ahead with the uh, task, which will be 2 minutes reading time, followed by 10 minutes performance time, strictly what I want it to be. Uh, After that, we will go ahead with feedback to the presenter. Then, answer key. This answer key will be divided initially into do's and don'ts and approach to perform in labor board task. And then the answer key of this labor board followed by domain scoring. And once the domain scoring will be completed, we will open our question and answer channel. So the presenter is ready today.
Yes, ma'am. This is the most difficult task.
Yeah, so we will try to make it very easy. I'm starting your 2 minutes time.
Ma'am, next slide. Ma'am, more rooms.
No. Started your 10 minutes.
Hello, I'm Shweta. I'm ready for the discussion. So I have taken the labor charge at 8:30 a.m. I have been provided with adequate staff, and I will be assigning my staff as per their competency, and I will be going room by room, and will prioritize it as urgent, semi-urgent, and routine. So coming to room number 1, she is a primary gravida, 29 weeks in early labor with preeclampsia. I would like to know about her current vitals, her abdominal findings, her vaginal findings and any signs of impending eclampsia and any investigations being done so far or not. Okay, so it's a case of impending eclampsia. It's a case of an impending eclampsia. So it's an urgent case for me. I will be sending my anesthetic registrar to go and assess the patient along with a midwife and give her, monitor her, check her, since I can see that her fetal heart rate is not on the Doppler. So get a CTG done. If not possible, then we can go ahead with the um, ultrasound, bedside ultrasound to be done. We'll inform the consultant about this case, and we will be trying to. And since she's on magnesium sulfate, we need to monitor her need signs of magnesium toxicity, and calcium gluconate has to be kept ready. And if there is any toxicity, then we have to give that as well. And once a patient gets stabilized, we will be delivery. The mode of the delivery will be discussed with the consultant, and she will be delivered. And since depending upon her condition. So room number 2, ma'am, I can't see the room. Room number 2 is CTG training by. There is a training going on for CTG for students.
By midwife, yes.
Okay, so it's a he will be continuing that, and if I am free later on, I can also attend this. So room number 3 is a primary 29 weeks planned for an induction of labor for IUD. So I would like to know any risk factors for IUD and what her abdominal findings and her vaginal findings are at the moment. Okay, any
She's
abdominal. Okay. So, since she's aware about all this, so induction of labor. So it's a routine case for routine case for me. A midwife can go and assess the patient. Induction of the labor will be done as per the protocol, depending upon the Bishop score, and hmm, and we'll discuss this. And since she's ma'am. Room number 4 is a primary breach in labor. I would like to know her period of gestation. Is it a diagnosed breach, undiagnosed breach, and her abdominal findings, her vaginal findings, and if any CTG is there. Okay, so it's an urgent case. It's a preterm breach in labor. It's an urgent case. I will be going myself to the patient, and I will be telling the patient about that she's in labor, and since she will be discussed about the mode of delivery, the vaginal versus cesarean, and I will inform the neonatologist for the availability of cord and the consultant. If she gives the consent for the cesarean, then we'll be midwife will prepare her for the cesarean, and the preterm cesarean will be done, and there are chances the baby will be admitted in the NICU, and anti-T will be given if the baby is RH positive. Room number 5 is a 34 multi-gravida with 34.6 weeks of twins in labor. I would like to know type of twins she has, her previous deliveries, how were they conducted, and her abdominal and the vaginal findings. Okay, so she's a dichorionic twins with both cephalic, and she's 3 centimeter dilated and steroids given. So I will be informing my, it's an urgent case as it's a preterm breach. So I will send my, it's a semi-urgent case. I will be sending my midwife to go and work up the patient. Continuous CTG monitoring, dual cardiotopography will be done. IV line, group and save will be kept ready. Patient will be informed about this. And if we'll discuss this with the patient and the consultant and the neonatologist for the that the cot is available for the twins, and if the patient goes into spontaneous after 4 centimeter, intrapartum antibiotic prophylaxis will be given if patient goes in active labor, uh, hmm, and magnesium sulfate for neuroprotection will also be given. Room number 6 is a 38 second gravida, previous cesarean in labor. I would like to know about her abdominal findings, any scar tenderness, her how is her CTG, her placental location, and her vaginal findings.
Okay. She is 3 cent. She's in early labor. No signs of scar tenderness, and the CTG is there. I will
Okay.
show you CTG.
Mhm. So the CTG is fine, and CTG seems to be fine, and she is in early labor. So if the patient, so I would like to check whether she has indication
You are not.
vaginal delivery. So midwife can monitor her, continuous CTG monitoring, labor care guide after 4 centimeter.
You are not audible.
Hello.
Yeah. Now it
It's
is.
it's a semi-urgent case for me. Midwife will go and monitor continuous CTG monitoring. Labor care guide will be done, and IV line, group and safe. And anytime if there is any bleeding or any scar days and signs, then she will be informing me. And we'll be informing the consultant also. We'll be keeping consultant in the loop. Next patient is a 40 weeks referred by midwife in view of community full. I would like to know, is there any comorbidities? Is she in labor? Her abdominal findings? Any risk factors in this patient at the moment?
No. Only
Okay.
high cephalic head.
Okay. So, so I would like to rule out any malpresentation. I would like to rule out. It's a routine case for me at the moment. A midwife can go and assess the patient. Look, I would like to know a scan to see the estimated fetal weight as well. And since the induction of labor can be planned later on once all the emergencies are being dealt, since and we have to rule out any cephalopathic malpresentations in this. And whenever if the high head is there, then we might have to go ahead with the control contraction in the later stages. So this has to be kept in mind. And room number 8 is a primary planned for induction of labor for recurrent reduced fetal movements. I would like to know any a period of gestation, gestational age for this patient, and what are her current findings at the moment, abdominal and the vaginal findings. She is that. Ma'am, can you show me the that also tachycardia dehydration? The
Just wait. You are able to see now?
yes, ma'am. Where is this? So she has tachycardia and dehydration. Okay, so which room were you showing me? Room number 8.
8. Yeah.
Yeah. This is a candidate for an instrumental delivery, but this is an urgent case for me. So she will be going for an instrumental vaginal delivery, and the delivery can be done by me. Depending upon the station of the head. If the station is at 0, then the instruments will be taken at in the theater, else it will be done in the labor room, depending and the consent has to be taken, and neonatologist has to be kept present at the time of delivery. Room number 9 is a teenage pregnancy with suspected rupture of membranes. I would like to know about her abdominal findings, her vaginal findings. A post speculum examination has been done or not so far? And is there any signs of choriamnitis?
No.
Okay. So where and is there any leaking at the moment?
It is no details are available as of now,
Mhm.
but no signs
So
of
I will,
choriamnitis.
okay, so it's a teenage pregnancy, entire total. We have to rule out all the, we need to see the safeguarding issues in this patient. It's a semi-urgent case. We have to be very sensitive. Emotional support has to be given. Safeguarding services are to be involved, social services, and we need to rule out any kind of domestic violence as well in this patient. And if that is, then we have to alert everyone. We have to do a gentle abdominal first speculum examination to check for the leaking, and we have to manage it accordingly. And if there is any leaking, then we'll be giving her steroids and magnesium. Steroids will be given, and antibiotics will be given to the patient. And we'll be informing the neonatologist and the consultant about this patient.
Okay. Anything else you wanted to prioritize?
No, ma'am.
Okay. I had given you 1 minute extra. Okay. Mm, anything else you wanted to add?
No, ma'am.
You would like to prioritize how you are going to go ahead?
Ma'am, can you close this?
Okay, sorry, dear.
I still can't see any slides. Ma'am, there is no slides.
Am I audible?
Yes, ma'am. Now you're audible.
Yeah, I don't know. Okay. So, do you want to prioritize it?
Ma'am, I can't see anything.
No. Do you want to prioritize which room you will be going, which room, how you are going to go ahead? You had prioritized first, second, means which is urgent, which is semi-urgent, but which will be the first one to be attended, followed by how means where you will be sending next urgent and the next after that the routine ones. Can you able to do that? Okay. So, uh, shall we go ahead with the feedback? Hello, am I audible?
Yes, ma'am.
Yeah. So, shall we go ahead with the feedback?
Yes, ma'am.
I don't know. Shweta had. Yeah. Okay. So, Shweta, I don't know why
Yes.
the network issues are there today. Uh, good job. There are few points which you were missing in certain situation.
Mhm.
Few points room wise. Uh, but overall a good approach when it comes to labor board. Okay, we will definitely go what are the do's and what are not, what you are not supposed to do in labor board. One
Yeah.
thing is not reading out the information whatever has been given to you. So you
Mhm.
read it out the information in first room. Rather than that, identify the situation, what I used to say always. Identify
Mhm.
the situation, what is the situation, and then anticipate the risk associated with that. Hmm?
Yeah.
So, and then you can formulate the plan very appropriately. When once we will be going through the points, you will realize what exactly I wanted to mean.
Mhm.
Uh, you covered up few points in the first room. Most of the points were missed in your case. Prioritization, stabilization, and decision to deliver. These was two important points which you could able to mention. And you mentioned about the blood investigations also. But there are certain other points which we need to add upon. Okay. We will see whenever we will be going ahead with the answer key. Secondly, CTG training by midwife or by anyone to the trainee. Uh, you just need to skip it, go to the next room. If possible, you can attend this training once you will be having adequate time. That is what you need to say here. Thirdly, you identified the risk factor here. You identified it was a routine case. Midwife will be going here, and IOL according to protocol, depending upon the bishop score, what you wanted to say, which you had said. But what about the risk factor which was there here? You didn't address the risk factor. Smoking.
Ma'am, sorry. Can you show the
We
screen?
can't see the slide.
Okay. Now,
Yes, ma'am.
okay. So risk factor which was there in this task was smoking. You couldn't address the smoking. So that also you need to address. Okay.
Mhm.
Uh, then the
So,
brief
ma'am,
presentation.
smoking services in this.
Offer quit smoking services. See, you are going to offer her this SAND support group, bereavement counseling, and the smoking services, BT risk assessment. Two risk factor here.
Okay.
Okay, so that is
Mhm.
an important point. VT risk assessment. Quit smoking, okay. If at all, it will not come to your mind. Smoking, IUFT, these two things should come to your
Mhm.
mind.
Okay.
VT risk assessment. Then breach presentation, yes, very nicely you had identified and you had prioritized as also emergency case, and uh, you had decided to go ahead with the C-section. Here, yes.
Yes, ma'am.
Okay. Uh, then the next case was preterm deciduate twin gestation. This was also this was you prioritize initially as urgent, then you prioritize as a semi-urgent, but I will still prioritize as a routine case. But because no harm in this case, okay. So basically, preterm labor. You didn't ask about the PVPA findings, okay? She's in early labor, according to me. She's not in advanced labor. Steroids were given, antibiotics and magnesium sulfate you considered. Then dual channel CTG you mentioned, group IV line, and informing of the NICU, checking availability, and consultant will be in loop. You had mentioned about most of the points here. Only what are the anticipated risk associated with twin gestation you have to mention, measures you have mentioned, but anticipated risk associated with this pregnancy you have not mentioned that. So PPH is an anticipated risk. Okay, you have to
Mhm.
say that. Okay, so routine per se, active management of third stage of labor you have to say because you are anticipating PPH. 30 room number 6, actually you had mentioned that you will be going ahead VBAC. Why you think that the patient will be opting for VBAC?
Ma'am, I thought there was written no contraindication for. I thought she is planned for VBAC. There was something written in the
Plan of
presentation.
action, C-section at 39 weeks.
It's POA is plan of action. Okay.
At 39 weeks.
Okay, I
Okay.
misread this. I thought it was previous cesarean at 39 weeks. Okay, ma'am. Yeah, my fault.
Yeah. So this is
Mhm.
actually, she's a case with previous, she's planned for C-section at 39 weeks of gestation, but now 38 weeks she had come in labor. So that
Mhm.
assumption actually, so here there will be a two channels open. Whether means
VBAC
at what,
versus yes.
yeah, any scar tenderness, scar essence you have mentioned, no. CTG you wanted to see, which was normal, you interpreted rightly. Then now coming to the plan, okay, whether there is any contraindication for VBAC, because if at all, if the patient is in advanced labor, so can we go ahead with the VBAC after discussing with the patient? After discussing with the patient, but if at all there will not be any contraindication, but this also we need to discuss with the patient and the consultant whether patient can go ahead with the planned C-section, or she may reconsider her decision to go ahead with VBAC delivery. Okay, so depending
Okay.
upon both the things, you have to go both the way. So if she opts for VBAC, whatever points, IV line, group and save, CTG, continuous CTG, watch for scar tenderness, inform me SOS, semi-urgent. Yes, rightly you had identified that she is semi-urgent to be managed by midwife. But if at all she decided to go for a planned C-section, category 2 C-section it will be, and it will be IV line, NPO, pre-medicines, theatre, consultant, neonatologist will be informed. Instructions will be given to the midwife and the patient will be shifted. Yes.
Yes,
These
ma'am.
are the points, yeah. Last, this is actually in the next room. You mentioned controlled cord traction. Oh, no, not controlled
Control
cord traction.
ARM.
Yeah, controlled ARM actually is a word.
ARM.
Yeah, so
Okay.
such kind of things do happen, and that's the reason you need to practice more and more labor board just to get a hang on your nerves, because you are nervous, because you think, oh shit, how to do it. So use each word very wisely when it comes to labor board. Hmm? Okay.
Okay, ma'am.
Yeah,
Hmm.
so that was basic. I understand what you wanted to say and why you said that word. Uh, then next question, next patient you got confused. Recurrent fetal movement, and then why the tachycardia and dehydration you didn't understand. But she's fully dilated, epidural analgesia, and
Exhausted.
exhausted mother. She was exhausted mother. So what are her findings as of now? +3. So here what you exactly mentioned? I was admitting someone, so missed out on few points.
Ma'am, I said it's an indication for a instrumental vaginal delivery,
Yeah, I
depending
know.
upon
Yeah, OVD you mentioned. Then what you
hmm,
then after that, who will be going?
depend, depending upon the station of the head. It
Hmm?
if it is high head
Plus
zero
three.
station, then it will be
Plus
at
three.
the
+3. You need to ask the station, okay, whenever you are thinking about OVD. Okay.
mhm,
So
yeah.
before saying OVD also, because here you need to think about the station. So always remember that +1 station if they had given. If they had given +1 station, then there are chances of failed OVD, okay? Because the station is little high. You are
Mhm.
going to shift this patient to the theater, and it will be a trial of instrumentation at +1 station. +2 and onward, yeah, you can very easily apply a instrumental delivery. At +1, assessment in theater, and depending upon that, it will be either C-section or trial of labor. Okay,
Labor.
+1. Okay,
Mhm.
+1 and above, more than +1 means +2 and above will be instrumentation where you can apply instrumentation. But +1 with LOP means ROP, you means here you have to consider that CPD ruling out malpresentation, malpositioning, and you are going to shift this patient to the theater, and depending upon that only you are going to decide your further action plan. Okay, there are more
Mhm.
4 people actually. Chalo nahi.
I'm Dr. Anjana, doctors in the
Okay, that is very important. What I wanted to say. So
Mhm.
OVD, do not say OVD if you are saying full dilatation. Just see, assess the station, and depending upon that, you say. Then consent and all those points, neonatologist, all those points needs to be mentioned. Okay, consent you mentioned. Neonatologist, I do not remember, but consultant you involved here. Yes,
Yes, ma'am.
yeah. CTG also you mentioned. And last case, the points were appropriate. Okay, here the points were appropriate. I was not having any issue in this room. Okay, so now going to the
Oh,
okay answer key. Okay, everybody is there now. We can discuss the exactly how to go ahead in labor board. Many a time, many people find it very difficult to understand the labor board and managing labor board within that stipulated time. So it's all about effective time management. 2 minutes of time to identify the risk in each room if you're thinking of going room wise. But sometimes they might be showing you the normal scenario, and once you enter and you ask the information, the scenario will be totally changed. That might be a emergency situation or a unstable patient where you need urgent attention. So initial after initial assessment, you may not be able to know which is the urgent room and which will be the non-urgent room. So it's identify your approach, what exactly you wanted to do. Whether you wanted to go room wise or you wanted to go to the urgent room first. Whatever way you wanted to choose, you can go ahead. Okay. Organize your thought process, but this thought process will not be organized at the time of the exam. This thought process you need to develop from now onward. So practice more and more labor board. It will not be done without any practice. Once you had entered into the labor board task, helicopter view is very important to see which are the rooms where you need to identify and you will require your urgent emergency, so that at least if you will not have a time, you will come to that room very quickly. Okay, so identify that room which is needing your urgent attention, and they will be providing you your own labor board. Okay, so at least tick mark that this is my urgent room. I should not be skipping on that room if there are multiple rooms. 10 rooms, 1 minute time each room will be an appropriate way to divide. Wherever there will be an emergency situation where you will need to take more information, more points you need to cover up, here you can cover up with these rooms which are non-urgent at that time. Okay, so there are certain rules when it comes to labor board discussion. Please remember all these do's. Entering, whenever you are entering into a labor ward task, prioritization task, be calm and compose. Many a time, just by listening or by just seeing that, oh, this is labor board, you may get fumbled, you may not, you may feel that you are less confident in this task. Introduce yourself appropriately. The way she has introduced was perfect. I do not have any issues when it comes to introduction. So the introduction was very appropriate according to the task, because here you need to know whether where exactly you are, what is your time, uh, which team you are having, and what is a competency. So situational awareness in this team, in this case, will be your team, your time, and seniors availability. Many a times they will be giving, he will be busy, he will be having 30 minutes time at home, at emergency surgery, something or the other things. So if your consultant is absent at that moment and can't be available, so do not forget to involve other consultant. Whosoever a consultant will be available, at least say this word, do not forget to involve other consultant. Assess your team's competency by asking. Please ask. So you are having your ST2. You would like to know whether the person can apply the forceps. What are his competency? Whether he can go ahead with a simple C-section. Okay. So you have to ask. Midwife, you will not be aware of that, but at least your ST2, you need to know what he can do independently, which is very important, because then you can assign that task. If he is competent enough to go ahead with the second, means low forceps deliveries or outlet deliveries can be done by ST2, then you can very easily assign that +3 station delivery to your ST2 without supervision if he has achieved the competency. You got my point, all of you? So always assess the team's competency by asking. It depends upon you how you wanted to start your room, but do not go blindly thinking that this is my urgent room. It might be a semi-urgent because the stage patient has been stabilized by the time you had entered. So whether you wanted to go room wise or urgent, identify your approach and practice it this way only from now onward. Do not change nearing exam, which is not feasible. Identify the situation, what it is, whether it is emergency or urgency. After identify the situation, the next important part is anticipation of risk. So situation, anticipating the risk, and next will come information gathering. Okay, so after anticipating the risk, you wanted to see whether the patient is already in having that risk, something like CTG, partogram, MEOS, or examination. I just wanted to give you a scenario. If the patient is previous LSCS is for VBAC, so what is the risk? Anticipated risk here will be a scar adhesions. So you have to say that the case of VBAC is at risk of scar adhesions. So I would like to know her observations, vitals, her CTG, and her partogram. So you are going to say that vitals will tell you and the CTG will tell you about the anticipated scar adhesions or impending scar adhesions. So once you had completed this information gathering, then you are going to take measures to minimize the risk. What measures? So if the patient is at risk of scar adhesions, so you are going to put IV line, you are going to group and cross match the patient's blood and blood products will be kept ready. The theater will be informed, the consultant will be informed, and the patient will be put on continuous CTG monitoring. Any signs of impending scar adhesions, you will be informed immediately. This will be your instructions. So measures to minimize the risk is very, very important. After that, prioritize. So now, depending upon the situation, whether the patient is stable, unstable, prioritize as urgent, semi-urgent, non-urgent, or routine. Assign according to the competency. So if you think that this is a patient which can be managed by your midwife or your ST2, you can assign it. And whom you are going to assign, please name it. I will suggest you to assign the labor room by the end of your assessment of that room. Do not assign the room in the once you had entered into the room. Do not assign the task and assess the emergency once you have entered into the room. See the situation, then by the end of the room you can assign and assess the prioritization. Assess need for additional manpower if at all. In this task, you can very easily say that all the rooms were manageable. But sometimes there might be a labor board where there are multiple rooms which will be requiring a urgent requirement, all of you. Okay, so you will be confused at that time. You will definitely get confused. Oh, this is urgent, that is urgent, or this is urgent. So please don't get confused. At least say this word: I would like to involve the team additional manpower here. I would like to call a help urgently. So would like to talk to the relevant personnel. If you are not knowing a rota manager, or you are not going to discuss, you are not going to know whom are going to put all those things. Okay, so you are just going to say, I would like to take additional help and need to arrange additional manpower because I can see there are multiple emergencies at a time which I will not be able to, me and my team will not be able to handle at this point. Okay, so this is very, very important when it comes to additional manpower and additional help. So what are don'ts in this task? What are the don'ts in this task? Am I audible, all of you?
Yes, ma'am.
Yeah. So reading out the information, whatever has been given, we do practice reading out the information. Please do not read the information given to you. We will see how we have to go and prioritize. Do not panic. Do not panic. If you are at all having a low confidence, still stay calm and answer boldly. That doesn't mean you will be using any unsafe words. The important point when it comes to labor board answer key is use all your words very, very wisely. Do not use any word in the moment of rush, in the moment of panicky, because if that will be the situation, most of the time you will use a unsafe act or unsafe words and they will mark you unsafe then. Do not forget to involve your specialties, your other specialties whenever required. Do not forget to take extra help whenever required. Making unsafe decision, as I had mentioned, that once we get complicated or clogged by that panicky attack, we may take unsafe decision. If it is a plus one and you will be thinking plus one station and you will be thinking of applying a forceps in the labor room, so sometimes these decisions might go. So the ideal answer for this plus one station will be, I would like to ship this patient to the theater. We'll assess per vaginal examination, will rule out CPD, will rule out malpresentation, malformation, and if it is feasible for me to apply instrument, then I will may go ahead with the trial of instrument. Otherwise, I will straight away go for second stage cesarean section. Uh, Okay, so this will be an ideal answer rather than making unsafe decision at that point. Missing out on urgent cases, big no. Do not miss out on urgent cases because that is a game changer. Missing out on prioritization and assigning the task in the uh, way in while presenting, while doing a presentation, many a times because of the stress of the exam, you forgot to prioritize the cases and assign the task. So go systematically from the very beginning. You will not miss out on prioritization and assigning the task. So once now, how we need to approach the task. So once you will be entering into the respective room, what exactly you are going to do now? Okay, so identify the situation that will be S. Our first room was having a primary gravida, some weeks of gestation with referred. Okay, so we will just go and see the room. Okay, so this is primary gravida, 29 weeks of gestation, which has been referred from community in view of 14 BP, which is 140/90, and her proteins are 2 plus. FHR are not audible on Doppler as of now. So with this situation, with this thing, what is your situation here? So my situation here will be a case of severe preeclampsia, because you know that proteins are 2 plus 140/90. Okay, so at least not severe preeclampsia, but you can say at least a case of preeclampsia. So that will be my situation here. Okay, so if the case will be of if the case will be of severe preeclampsia or preeclampsia, then you need to anticipate the risk and information gathering for that risk, what we had discussed in DO's. So what are the anticipated risk with preeclampsia? So the risk of preeclampsia will be risk of eclampsia. Okay, so anticipated risk will be anticipated risk of eclampsia, and the risk and complications of severe preeclampsia like HELP, DIC, uh, IUD, abruption. So these are the other risks. Okay, so these are the other risks. Next will be measures to minimize the risk. You have to say all the measures, and assigning and prioritization will be your last. So go systematically. Situation, anticipation of risk, measures to minimize the risk, and assigning and prioritization of the task is the last thing what you are going to do now. So let's go room wise. So situation here, a preeclampsia in preterm labor with FHR not audible will be the ideal thing. Okay, ideal thing to say. We may not be able to do this, but if you will continuously start practicing, you will definitely start identifying the situation. Okay, uh, at risk of eclampsia and complications of preeclampsia, I would like to gather certain information here, which will be whether there are any signs of imminent eclampsia. So first will be history, followed by examination, followed by treatment and blood investigations. Okay. Now, what are her current observations? I wanted to know her current observations, especially her BP, DTR, urine output, and fetal well-being. Okay. What treatment she is on? What treatment she is on? That means I wanted to know whether she is on antihypertensive or magnesium sulfate. What are the investigations for maternal and fetal well-being has been done? So blood investigation, USG, CTG or USG, you can say both, any of the situation, because you wanted to assess fetal well-being also here. So my answer to these questions will be referred from midwifery unit in view of severe preeclampsia, headache, which is an imminent signs of severe eclampsia. Okay, her BP as of now is 180, 110 with DTR positive in both the extremities. The patient is currently on labetalol and magnesium sulfate. So this was my information which was given to me. The patient is in HDU. Now my management, now my anticipated risk completed. So how I'm going to take the measures to manage this patient? Everybody can assess that this is a top urgent case for you and this is an emergency situation. I always say that at least use this buzzword of CRMA protocol. Do not forget to activate the CRMA protocol. The aim of consultation, aim of this my treatment will be stabilization of mother followed by delivery, even if it is IUD, because FHR are not visible, audible. So stabilization of the mother followed by delivery, even if it is audible, even if FHR are not audible. So call for help. If you think that you are having time, then you can involve the people, and you can tell who will be involved in the care. But at least major people you wanted to involve here will be ST5 anesthetist and your consultant. Do not forget these two people. Then you can involve HDU consultant or HDU ST5. Stabilization of mother will be there. Anesthetist consultant can also be informed. He may come, he may not come. Alert blood bank, porter, and scribbler. Okay. Theater, as of now, we are not involving here because our priority will be to stabilize the mother. But as of now, the HDU people, anesthetist, consultant, and senior midwife preferably, whosoever extra help you can arrange, you can help here, arrange here. A blood bank, because you may require blood and blood products, porter and scribbler. So this will be your call for help. R will be ABC approach, as I will always say that ABC approach. Oxygen needs to be started by mask, 15 liter per minute, 100%. Two wide bore IV line cannula, blood collections for baseline blood investigation, if at all not if the blood collection has not been done, at least say baseline blood investigation. Group and save. Okay, group and save is very, very important because this patient is at risk of PPH also. Start the patient on crystallite followed by colloid, but restricted fluid will be there as the patient is at risk of pulmonary edema. So 80 ml per hour will be the options of this case. Management and assessment will be continue labetalol and magnesium sulfate. Due to magnesium sulfate, the patient is at risk of magnesium toxicity. Keep a watch for that. Keep calcium gluconate ready. Catheterize and monitor her parameters continuously, including her blood pressure, respiratory rate, DTR, on NEOS. Arrange CTG or USG for fetal localization. Rule out fetal demise. After that, patients will be decision will be taken to deliver depending upon USG. Once the patient will be stabilized, then only we are going to decide whether what mode of delivery will be there. But our primary aim here will be stabilization of the patient. Okay, am I clear regarding this room, or anybody is having any doubt regarding this room? Am I clear?
Yes, ma'am.
Okay. So this will be my top priority. My consultant will be informed, including the ST5 anesthetist and HDU people. If the HDU is beside the labor room and there will not be a separate HDU personnel who will be looking after, then ST5 anesthetist and consultant will be informed. This will be my top priority while managing this case. Okay. So we had completed our room 1. Our room 2 is CTG training. So training to be done by midwife as planned for the student, for whichever. What is the topic? Okay, for whom you can ask, and any help required, I will be offering their help, and if I will get time, I may attend it also. Okay, so this will be my sentences in this room. Now coming to my room number 3. So situation here is induction of labor in case of intrauterine demises. So what information I would like to know? So what are the risk factor for her demise? Okay, so information will be risk factor for her demise, whether there is any risk factor. If they will, most of the time in labor board, if you will be saying risk factor also, you may not need to say each words individually. They will give you the information. Okay, the history of smoking is positive. If at all you will able to say IUGR, SGA, preeclampsia, and smoking, these are the commonest risk factor a baby can have during the risk of IUD, even congenital abnormalities. Okay, so whether the BBN has been delivered for this patient or not, if not, the BBN needs to be delivered. Arrangement of SAND support group and bereavement counselor. What are her vitals? What are her bishops? per vaginal examination and per abdominal examination, I need to know, because this is the information I need to know, an investigation of a cause we wanted to know. Okay, so investigation of a cause we wanted to know here. So now the ideal answer here will be, now Shweta, you will listen, you will see what points you had missed out on this case. Okay, so
Yes,
the
ma'am.
smoking was positive, BBN has been done, presently talking to bereavement counselor, which has been arranged by midwife, and a SAND support group details has been given to the patient. The parameters, vitals, and bishops are stable. The patient is as of now stable. Uh, Bishop score is more than 5 centimeter. Baseline all investigations has been sent to look for the cause for IUD, including urine cocaine. Discuss postmortem here. Okay, so we need to discuss postmortem since case of stillbirth. VT risk assessment needs to be done and offer accordingly. This case will be on topmost last on my priority. She will not be a on be the first on priority. She will be the last on priority. As of now, she is a routine case. A midwife or a ST2 can handle this case as of now. Okay, and induction of labor according to the unit protocol which you had mentioned, but after stabilization. After stabilization, because you can see that you do not know as of now how many people, how many patients will be requiring your immediate attention, dear here. Okay, so if there will be any upcoming case which will be requiring my immediate assessment, then depending upon the situation, I may be assessing apology for that. This will be last on priority. Once this labor ward will be stable, because you can see that there are 9 patients which may require your immediate attention. So once the labor, at least say this word, once the labor ward will be stable, I will personally go and ask some ST2 or the midwife to, even ST2 can induce her, or midwife can induce her, induction according to the unit protocol. Okay, you got my point? Now coming to the room number 4. Okay, so what was the room here? A breech which is undiagnosed in labor. The gestational age was not given here. Sometimes they may not give you the dilatation. They may not give you the type of breech also. So what is the gestational age and type of breech? So the answer is 29 weeks and it's a complete breech. So you would like to know what is the cause of preterm, whether it is infection, whether it is abruptio. You wanted to know at what stage of labor the patient is. Okay, at what stage of labor the patient is. The patient is in advanced labor. She's having 6 centimeter in advanced labor, getting 3 by 10 by 30 activities. Okay, vitals are stable per abdomen, 3 by 10 by 20 activities. FHR normal, CTG normal. You can say PV 6 centimeter, membranes plus. Okay, so my diagnosis here will be changed and it will be a advanced labor, the breach in advanced labor. Okay, uh, at risk of, now my risk, what are the risk of this case will be the risk of prematurity and the risk of labor. Okay, because breach needs expertise, some interventions like CS or vaginal breech delivery, if at all we need to go ahead with this. What treatment the patient has received, whether the patient has received steroid, magnesium sulfate, antibiotics, place in NICU is available or not, arrange for CTG, arrange urgent bedside ultrasonography if feasible, otherwise not possible. Discuss pros and, now whenever this kind of situation is there, whenever this kind of situation is there, here you have to discuss pros and cons of both the options with the patient, going ahead with vaginal breech birth or preterm LSCS. Its pros and cons and implications on future pregnancies will be discussed with the patient, and consultant will be in loop. So what are her options? What are her options? Whether the patient has opted for LSCS or whether the patient has opted for vaginal breech birth. So if the patient has opted for LSCS, then communications will be here. Alert the theater, consultant, anesthetist, your own consultant, theater staff, and neonatologist will be informed. Consent by ST2. Always remember IV line, group and save, NPO and pre-med. If the patient has opted for LSCS, patient will be shifted to theater for category 2 C-section. Always remember that you have to say a category 1 or category 2 at least. Okay, so category 2 C-section, the patient will be shifted to labor room, theater. But if at all patient has not patient has opted for a vaginal breach, see to it that there will not be contraindications to vaginal breach. Ensure skilled attendant consultant will be in the loop, neonatologist will be informed. These are the only points, and consent will be there for both the options. Okay, blood group is Rh negative, so anti D after ruling out JO witness. Prioritization will be, she will be a urgent case, and by ST2 if competency achieved, or me if not. Okay, if the competency for second stage for C-section has been achieved, although it's a preterm C-section, so depending upon that, it might be done by the ST2 or me. Instructions accordingly. She is urgent case. Okay, she is urgent case because she is in advanced labor. You cannot take a risk with this case, and you cannot prioritize this case as semi-urgent thinking that she's just 6 centimeter, because there is a risk of progressing this patient very fast, risk of head entrapment, a difficult vaginal breech delivery. So all those risks will put this case as a urgent case. Depending upon the situation, most probably you will be going for this C-section, but you can involve your ST2 also in the consent procedure. Okay. Now coming to the room 5. So room 5 was DCDA twin room. So DCDA twin, that is preterm twin in labor. It has not been mentioned what type of twin it is. Always remember, in twin, you just need to ask what is the type of twin. Gestational age, if at all not given, please ask gestational age, and presentation. What is the presentation of that twin? So anticipated risk will be, what will be the anticipated risk? Requiring interventions during labor, because a risk of if both the twins are one will be cephalic, other will be breech, so there is an increased risk of interventions, and PPH. So these two things you have to manage simultaneously. So what are the measures, and what is the information gathering you would like to know? Type of gestational age, so TCDA 34.5 weeks. Any complications of twin pregnancy? No. Previous mode of delivery, she is G2P1L1. Okay, so any, what is her previous mode of delivery? So it is vaginal. Presentation of twin 1 and twin 2, it is cephalic. So she can be delivered. Okay, at what stage of labor? At what stage of labor? So would like to know per abdominal and per vaginal findings, which is 3 centimeter in early labor. Steroids given, NICU available. Management will be now chart labor on partogram, dual channel CTG, access to USG should be there. If inactive labor, IV line, save, group and save. Steroids, check NICU. Twin 1 to be delivered as singleton by midwife. Offer routine labor care, what she has mentioned. Okay, and active management of third stage of labor after the delivery. So she will be my routine case. She will not be urgent, because 3 centimeter preterm labor, preterm twin with cephalic presentation, DCDA with none of the complications, I will prioritize as a routine case. This can be done by a skilled midwife. The patient can be delivered by a skilled midwife. Patient may not require, but yes, I will be informed whenever there will be any deviation from normal. Okay, so routine labor care, active management of third stage of labor, midwife will be doing this. Okay, you also prioritize this case as semi-urgent, and
Semi-urgent, ma'am.
yeah, semi-urgent. And whom you sent here, I had not mentioned here. I had not mentioned. Okay, whom you had
Okay.
sent. Okay, so that was not been mentioned here. Now coming to the room 6. So we all know that this is a case who has previous LSS, who was planned for C-section, but now she is in labor. What is the reason for planned C-section? What are her labor plan? Whether it is because she's been there is contraindications to as VBAC, and that's the reason they had planned for C-section. If it is so, then there isn't any thought you will be directly taking this patient for the vagina C-section. No VBAC will be offered. Anticipated risk will be, she is at risk of scar dehiscence or uterine rupture. Any sign suggestive of scar dehiscence? None. CTG for FHR monitoring and CTG for scar dehiscence. So signs of scar dehiscence will be FHR abnormalities and maternal vitals. At what stage of labor she is? So she is 3 centimeter as of now. CTG is attached, which is normal, which is again giving us a reassurance that the patient is not having any scar dehiscence. Review her labor plan. Review her labor plan. It is very important to review. Discuss now both the options of VBAC and planned C-section, means emergency C-section. Now she will go for category 2 C-section here. Both the options will be discussed with the patient and take consultant input and patient's input regarding the same. If patients opt for VBAC and reconsider her option, explaining pros and cons of VBAC will be there. Adequate pain relief, documenting her care plan. If not as per plan, if she doesn't opt for VBAC, then LSCS. It will be category 2 LSCS. Okay. Consent, NPO, pre-med, IV line, group and save. Inform the theater. Okay. Alert and inform theater. Whenever you wanted to decide for C-section or you wanted to shift to the theater, your categorization of C-section will be there. Consent, NPO, pre-med, IV line, group and save, inform and alert theater. Consultant and the neonatologist will be informed in this case also. Consent will be by ST2. Okay. If opting for C-section, as of now, she will be semi-urgent and it will be midwife who will be monitoring this patient. Okay. So you mentioned semi-urgent, you mentioned midwife, and you assume that we can go ahead with the VBAC. Yes. So that assumption should not be should not be done. Okay. So one tagline of me is assumption kills. Do not assume, ask. If you are in doubt, please ask. I will be talking to the patient and arrangements will be according to the patients. Okay, so whether it will be VBAC or whether it will be C-section, according to that we will be having that. Then that high head patient. Okay, why IOL, dear? You mentioned IOL in this case. They generally do not do IOL till 41 weeks and 3 days. Okay, so 10 days overdue is normal in their case. Low risk patient, only concern here will be high head. Any risk factor? She's having a high head. She's just for routine antenatal care. Why high head? No details available. Polyfibroid, none, no details available. So she is at risk. You mentioned controlled ARM. Okay, controlled ARM. We will consider that you mentioned about controlled ARM. But why controlled ARM? You need to mention that point. She is at risk of cord prolapse. So controlled ARM will be offered to patient once the patient goes in active labor. At what stage of labor? Last PV examination and rule out CPD. This needs to be done. 4 centimeter membranes plus presentation is vertex. So watch for progress of labor, partogram, FHR monitoring, routine antenatal care. So she will again be a routine case and midwife will be monitoring this case. Offer controlled ARM in this case. That will be my instructions. Partogram, FHR monitoring, a routine antenatal care will be offered to this patient. Okay, now we can see here that there are multiple patients. Sorry, so the community center is overburdened, so we can discuss this here also. Community with concerned member regarding the overburdening of the midwife unit at community. Why the community? You can skip this sentence. It's not going to give you any added advantage, but do not miss out on the important points. This case, okay, now this case is again an urgent case. So a case of prolonged labor. Okay, prolonged labor, exhausted mother as she is induction of labor in view of decreased fetal movement. So whether the patient is having any adequate pain relief, although the patient is on epidural, but whether she needs any top up. Stage of labor, vitals, observation, CTG. So her vitals are, she's having tachycardia. There are signs of dehydration, PV, sheet station +3, membranes are absent. The color of liquor is normal. Color of liquor is clear. So corrective measures. The first thing should come to your mind, a exhausted mother will be corrective measure. Hydration, adequate pain relief should be the first thing. Encourage active pushing if at all she can. Consider OVD as an option. very nicely. She has mentioned it. Inform consultant, neonatologist, and midwife to arrange this OVD. Consent for the same. Semi-urgent, midwife to arrange. Okay. Again, here you can involve your ST2, or if he has achieved competency, because the station here is S+3 station. IV line, group and save, active management of third stage of labor can also be added to this case, because exhausted prolonged labor is again at risk of PPH here. So again, you can add those points here, which I forgot to mention in this task. So you can very easily add IV line, group and save at risk of PPH. So active management of third stage of labor will be there. Neonatologist will be informed, consultant will be informed here. Room 9, a teenage preterm pre-PROM. So any safeguarding issues, safeguarding team has been there, and she has it has been involved. We do not know what are the vulnerable issues. Decision for baby regarding adoption, or whether the baby mother is going to keep the baby, it needs to be addressed. Involve social services. For PPROM, broad spectrum antibiotics. For PPROM, any signs of chorioamnitis, which she has very nicely asked. Broad spectrum antibiotics, check allergy, GBS prophylaxis, steroid is giving, magnesium sulfate, and ICU place and neonatologist will be attended. Now, investigations which we need to do here will be mother swab, FBC, urine to rule out any infection. We need to send all these investigations, because if the vitals are stable, still we need to rule out whether there are any signs of subclinical infection. Fetal investigations will be ultrasonography and CTG. So this is again, if the patient is stable and there are no concerning features for mother and baby, it will be routine and midwife needs to be arranged. So sequence here. My first case will be HDU case, which is my topmost priority, where I will inform ST5 and the consultant input will be in consultant will be also informed, and input of consultant will be taken here. Okay, so he will be informed, he will be asked to come and see the patient. Second case will be preterm breach. Okay, preterm breach. So it will be by section, you can do also. Section can be done by ST2 if he is competent. Competency has been achieved. Third case will be OVD. So if I am doing that case, room number 4, my third case can be attended by ST2 if competency has been achieved. Then followed by that, the category 2 LSCS by me. Okay, previous LSCS she is. So this can be done by me after finishing my room number 4C section. Because at present the patient is in early labor and there are no imminent signs of scar rupture. Okay, scar rupture or scar dehiscence. So this will be my fourth patient. In between, I will take input for other patients, and my last case will be IUD. Now the last part, okay, the last part will be a domain scoring. Domain scoring, one needs to know domain scoring for each domain, what exactly they wanted to assess you in individual domains. Okay, in labor board, what they mean to be. So when it comes to communication with colleague, okay, clear reason, clear communication, including your clear communication with the doctor or the teacher, examiner, that will be considered as communication with colleague. So when you will be presenting your task, when you will be presenting your task to the examiner, so that communication will also be taken as communication with colleague. So have a clear reason and clear interaction with colleagues, especially in handover cases. It is a team working. Many a times I have seen students saying, I will do this, I will do this, I will do this, I will put IV line, I will give antibiotics, I will do this, I will do this. Whenever there are emergency situation, delegating, okay, assigning a task to your team is communication. Okay, if you will be saying I will be doing, then it is a patient safety, you cannot do all the things. This is again leadership quality they wanted to see, they wanted to check by giving you an emergency task. So by giving you an emergency task, they wanted to assess whether you will be saying these sentences of I will be doing, or you are allocating each work to an individual or to a particular people. Prioritization of cases accordingly, that is urgent, semi-urgent, non-urgent, and delegate the task appropriately. Understands your own limit and your own competency, what you can do. If you can do a second stage C-section, you can do a second stage C-section. But if there is any re-exploration after a intra-abdominal bleed, suspected intra-abdominal bleed, then this case you are not going to do. Your consultant is going to come, and this case will be done by you. This case will be done by consultant only. Always remember this. Okay. Call for senior help and involve other specialties whenever required. Whenever required, please ensure your seniors will be there. If your seniors are busy, take a help of any extra consultant. Say this word, at least say this word. If my consultant is busy, I will ask other consultant to come and help me out. Whenever possible, give logical differential diagnosis. Okay, whenever possible, uh, give logical. There is one case of that fully dilated case is having that uh, means confused, disoriented. So here they just wanted to see what are the your differential diagnosis in this case. So it can be abruption, it can be embolism, okay, or it can be sepsis also, because the case of PPROM. So these are the way you are going to give a differential diagnosis. If you do not see, if you do not recognize in first hand what is the situation here. Okay, so just looking at this, you can say that this is emergency situation which I am able to see because the patient is unstable. That identifying at least that much is also important. Able to convey to the colleague, including the consultant offside. Okay, and whatever you have interpreted the information, convey it to your colleague, convey it to your examiner and consultant. I provide appropriate amount of details to ensure management plans are clear and easily understood by colleague. So giving a crystal clear management plan to be followed by your colleague is again communication with colleague. Appropriate teaching skills. Okay, what are the teaching skills here? Less likely this will be included, but means whenever necessary you can teach appropriate skills to your other colleagues whenever needed. And check the competency of your team member, which is very, very important. Now, what is information gathering? Most of the time, 3 or 4 domains will be included in this labor board. But communication with colleague, information gathering, and patient safety, these 3 domains are going to be there definitely. Applied clinical knowledge may or may not be there, but these 3 domains are going to be there. So what is information gathering in this case? Interpretation of labor board information, first thing. Asking a relevant information from the examiner. Okay, asking the relevant information from the examiner. From the midwife, means we are going to ask it, but in the real exam we are going to ask it to the examiner. Patient's condition, patient's clinical notes. Other modes of information gathering will be partogram, CTG, Meos charting. Use informations to formulate. This information needs to be implied into a clear clinical picture of the patients, and depending upon that, describe your action plan. Okay, information gathering will be that again, what plan you are going to give, and discuss the rationale for decision. Discuss the rationale for the decision with the patient also. Communication with patient and families will not be involved in this case, but as we had seen 2 cases here. Now there was a case of VBAC, means there was a case of previous LSCS which was going for planned C-section. So in this case, we need to discuss with the patient. Once we had discussed, the same situation will be in OVD. Okay. Instrumental delivery, the same situation in preterm breech. Okay, because here we are going to discuss with the patients. So this domain sometimes may be included, many a times it may not be included, but it is again considered into patient safety, whether you had given pros and cons of both the options to the patient. So do not forget that. So explain risk and benefits of any interventions for both mother and baby to the mother and baby. Discuss with the patient. Discuss abnormal labor, instrumental or operative delivery or CS need with the patients. Communicate to the woman and her partner for or the family for need for intervention if you are planning any intervention. Apology for delay in care. This is again a communication with patient. Consenting for procedure is communication with patient, but these are again the points which will be coming under patient safety domain. So what is patient safety? What is patient safety? The most commonest patient safety is using means a saying unsafe words, unsafe act during labor board task. What I have observed, even when I attempted my first exam, it was unsafe words which has come to my mind. And once after coming out of the exam room, I was like, shit, why? How I can say all these blunder things? Even if we will be in a normal situation, we may not be saying that, but it is exam stress. It is exam stress, and sometimes it is a fear of labor board, and we generally avoid practicing labor board. So my suggestion will be to practice more and more labor board, so that it will bring out that fear, and you will not at least use any unsafe words in the exam. Okay, this is a game changer. This is a game changer. Ensure safety at different environments, especially in water birth, birthing outside hospital, midwifery unit. Understand the risk and risk of interventions. Whatever interventions you are going to offer to the patient, understand their risk. Analgesia, therapeutics, invasive procedure, LSCS, C-section, whatever. Whenever possible, chaperone for intimate examination, able to maintain patient's dignity at all time, accurately prescription during labor, including management and intervention, intravenous infusion. Failure to anticipate risk. As I had mentioned, that this is the most another common mistake what people are doing. Whenever you have been given a situation, please anticipate the risk. What at risk of what is the risk associated with this cause? Safety of medication and its side effects. Acknowledge medical errors, poor care or omission, and apologies for the same. Understand risk management and clinical governance process in relations to intrapartum care, especially undiagnosed breach as term. This is the only way where you can involve clinical governance. Even if it is a busy labor room, that also you can communicate with the means risk management team, why, or the rota manager, why the labor rooms are getting overloaded, so you can communicate with them. Okay, able to critically appraise any adverse event if at all it is happening. Ask help if it is busy. Now coming to the last domain, that is applied clinical knowledge. So applied clinical knowledge, these all guidelines are very important when it comes to applied clinical knowledge and answering your labor board. So the guideline for intrapartum care of a healthy woman and babies, fetal monitoring, induction of labor, preterm, and that intrapartum care of a woman with existing medical conditions for or obstetric complication. So these are all guidelines are very important when it comes to having a knowledge about labor board station or labor board task. Ultimately, it is all pluses and minuses. You identify the situation, you develop your own skill. This is actually what I had got it. What are the competency of ST2 and competency of ST5? What at least they need to do. So you will have an idea that what are the tasks. The best way is ask your examiner what my ST2 can do or what my ST1 can do. So at least with this information, you can be safe enough for the labor board while allotting the tasks to your ST2 or ST1. And last but not the least, all the best for your exam. Keep practicing, because practice is the only way of doing labor board confidently. What we have seen. Any help, you can count us. We are always there. Thank you.
Thank you, ma'am.
Ma'am, very